is Josephine Tapper, and we're shifting our focus now to bipolar and the psychiatry context of use of valproate. So, Josephine Tapper, over to you.
Firstly, I would like to thank the EMA for allowing me to speak at such an important hearing. Although my title suggests that states that I'm a member of Bipolar UK, I stand here as an individual woman with bipolar who has received no input or indeed support from any mental health organisation. My thoughts are mine and mine alone and aren't evidential. As a woman with bipolar, I battle with feelings of shame, inadequacy and guilt. Therefore, I was petrified of getting pregnant whilst taking valproate due to its proven toxicity. All medical data has, for a number of years, clearly shown a direct correlation between the drug and fetal abnormalities and or developmental problems in the child once born. Women with bipolar may well be on other medications alongside valproate to treat the same condition or comorbid illnesses, complicating pregnancy further. They are also at far greater risk of depressive episodes during pregnancy, postnatal depression, and or postpartum psychosis. Any birth defects that arise due to valproate use also increase pressures on the long-term mental health of a mother with bipolar. For a number of years, UK guidelines have stated that valproate should not be prescribed for women of childbearing age. I have always had a very strong desire to have children and continually express this to my mental health teams. However, for a number of years, I had an unsympathetic psychiatrist who refused to stop prescribing valproate despite my concerns and requests. I was actually told, perhaps, given your illness, you shouldn't have children. Although I had never, and indeed have never, been detained under any mental health act. Eventually, my medication changed, but only after I was placed under the care of a different clinician. In the last few years, I have had psychiatrists who have been more supportive, but they are poorly equipped in discussing issues around pregnancy and bipolar. I am now on a mood stabiliser that carries far fewer risks to the unborn child than valproate. However, this is too little and too late for me. At the age of 46, I know that the opportunity to carry my own child has probably passed, and I will have to live with a profound sense of sadness and regret for the rest of my life. These feelings have a negative impact on my mental well-being and recovery, and I will always grieve. I hope that psychiatrists no longer adopt the same prejudiced and unsupportive approach that mine did. However, I suspect there are still pockets of bad practice. At no point was I ever given any information, written or oral, on the risks of valproate in pregnancy. I was a relatively engaged patient, but was only told about the risks by another service user, not by psychiatric services. All women on valproate who are considering pregnancy should be offered counselling on the pharmacological dangers. Guidance must be clear, evidence-based and free of bias. There should also be signposting to other agencies where necessary. Clinical and social support at this stage is critical, so that a woman's mental health is not jeopardised by any sudden changes to or withdrawal of medication. A woman who feels included and involved in her care plan is more likely to comply with treatment. resulting in a more positive experience of pregnancy and better health outcomes for her and her child. However, many women will discover they are pregnant whilst taking valproate. Given the current pressures on mental health services, and I speak of the UK, it is likely to be a general practitioner who will be the initial point of contact for these women. There should be an immediate referral to the relevant mental health services without the usual waiting time, even where a woman may have previously been discharged. Valproate titration can then begin and other drugs and/or therapies introduced. There should also be joint input from general practitioners and hospital and community maternity services to create a multidisciplinary care plan focusing on the physical and psychological. Finally, psychiatrists entering the profession today should be better trained in the area of pregnancy and bipolar and the ramifications. The same could also be said of obstetrics and midwifery. Women with bipolar have multiple health burdens and may have additional support needs. However, we are no different to any other group in our ability to provide loving, stable and positive family environments. The stigmatising attitudes of the past should have no place in psychiatry and the medical profession as a whole today. It is my fervent hope that women with bipolar considering pregnancy be supported in a way that I wasn't. They should be respected and enabled to make an informed decision based on their individual circumstances and aims. Perhaps the most important decision they will ever take in their life. Thank you.
Well, thank you very much indeed, Ms. Tapper. I think that you've clearly shared your own experience, but looked ahead to improve that of others, and that's tremendous and very altruistic.